I'm Dr. Ron Berkman, and this is part one of two videos. This particular video will be discussing changes occurring after delivery. However, upon completion of reading the book chapter on the postpartum period, viewing the two videos, of which this is one, and participating in a subsequent classroom session, you should be able to describe major physiologic changes of the puerperium, which is the focus of this particular video, as well as in the second video some of the common complications and problems, as well as how some of these are managed. And some of this will also be discussed during the classroom session. So if we look first at the vagina, certainly the vagina gradually diminishes in size, but rarely to nulliparous dimensions from the time of delivery on through the first 6 weeks postpartum. In addition, the rugae, which virtually disappear by the third trimester, also begin to reform and reappear by about halfway through or 3 weeks. However, due to lacerations which can occur at delivery as well as stretching, women may experience outlet relaxation, urinary incontinence, even pelvic organ prolapse, and with scarring from, for example, lacerations, they also may experience dyspareunia. The uterus itself also undergoes some dramatic changes. At approximately 40 weeks, the uterus alone weighs about 1,000 grams, which is 10 to 20 times pre-pregnant weight. But following delivery, the uterus rapidly involutes and in fact returns to the pelvis, that is, goes underneath the symphysis in about 2 weeks and reaches normal size in about 6 weeks. And as shown here diagrammatically, if we look at the top line, we can see the uterine length at about 1 day postpartum is 18 centimeters, but by 9 days postpartum has shrunken or decreased to about 12 centimeters in size. And if you look at the bottom chart, you can see there's also some change in the AP diameter during this period of time. The placental site and endometrium also go a degree of involution. Decidual sloughing that occurs at delivery, and as noted that there will be decidua in the lochia for the next several days. The basal layer adjacent to the myometrium rapidly regenerates, with endometrium achieving normal thickness as early as 2 weeks. With compression via uterine musculature and arterial smooth muscle contractions, there's hemostasis following placental delivery. And in addition, the vessels in the placental bed will undergo hyalinization, something that can be seen for several weeks or even months postpartum. However, if there's subinvolution of the uterus secondary either to infection or retained placental fragments, this can lead to prolongation of lochial flow and or even excessive bleeding, and certainly abnormal involution of the placental site can lead to late postpartum hemorrhage. If we look here diagrammatically, we can see on the right-hand side, under normal pregnancies, these vessels are dilated. There's in fact some AV shunts between the venous and arterial components. And then when we go distal towards the placental bed, you can see the vessels there also are somewhat more convoluted and dilated as well. And then when we shift just to the left and look at a immediate postpartum and non-gravid uterus, you can see that the vessels straighten out to some degree, but also the vessels terminally no longer have the same diameter that they had previously. And all this is occurring because of the contraction of the uterine musculature as well as the arterial contraction to again decrease blood flow, particularly from the placental bed immediately after delivery. There are also a number of hematologic and coagulation changes. There can be significant leukocytosis, which may occur in labor or immediately postpartum, with counts as high as 30,000, even though there's no evidence of infection. Also, near the end of pregnancy, a number of coagulation factors become abnormal, such as fibrinogen, and this creates a hypercoagulable state. And this is important to keep in mind, particularly as we talk about potentially providing contraception that contained estrogen, in that there is this increased risk for venous thromboembolism, particularly in the first 4 postpartum weeks due to these changes, as well as due to relative immobility of most postpartum patients, as well as vessel trauma. And as we can see from this diagram, that in the first 3 weeks, between 15 and 20-fold difference in risk of thrombotic events compared to a non-pregnant woman occurs for a immediately postpartum woman. So again, this is a substantial increase in risk of thrombosis due to these hypercoagulable changes. There are some dramatic cardiovascular changes that also occur. Blood volume increases to about 35% above non-pregnant values, as well as red blood cell volume also increases as shown. However, immediately after delivery, although the plasma volume is diminished by about 1,000 cc's due to blood loss, the total blood volume only decreases by about 15 to 16%. Further, by the third postpartum day, due to a shift of extracellular fluid into the vascular space, the plasma volume is replenished. By 8 weeks postpartum, the red cell mass has rebounded and the hematocrit usually is normal in most women. The pulse rate increases throughout pregnancy, as does stroke volume and cardiac output. Even 1 year after delivery, in fact, a significantly higher cardiac output has been observed in both nulliparous and multiparous patients, compared with pre-pregnancy values. So again, increased cardiac output is a change which may persist for long periods of time. We also see some change in the systolic blood pressure in particular, but again, nothing dramatic. And again, this sort of stabilizes by 5 to 6 days postpartum with a very minor change within the diastolic blood pressure. Ovarian function certainly is altered significantly. Ovulation will occur as early as about 4 weeks postpartum, with a mean of about 10 weeks in non-lactating women. Menstruation occurs at a mean between 7 to 9 weeks postpartum, with 70% of non-lactating women menstruating by 12 weeks. But once you are lactating and there's elevated levels of serum prolactin, this leads to suppression of ovulation. Thus, among women who are breastfeeding, the mean time to ovulation is stretched out to about 6 months. And if a woman exclusively breastfeeds, the likelihood of ovulation within the first 6 months postpartum is 1 to 5%, such that lactational amenorrhea is in fact, for several months postpartum, a very effective method of contraception. And we can see here this sort of slow return to ovulatory function among breastfeeding women, showing that only about 50% will achieve ovulation by 30 weeks postpartum, with almost all achieving it roughly 70 weeks postpartum. The breast also undergoes a lot of other changes. Colostrum begins secretion by about day 2 and can last as long as 2 weeks. Compared to breast milk, it tends to have more minerals, amino acids, and protein, but less sugar and fat. In addition, within breast milk and colostrum, there are host-resistant factors, or immunologic factors, which include IgA, complement, T lymphocytes, and macrophages. During normal lactation, the total volume of milk produced daily, and again, this varies substantially from patient to patient, is about 600 cc's. But even in the smaller amounts, there are virtually all the required newborn nutrients, immunologic factors, and antibacterial components. But again, all of this is affected by maternal diet as well as newborn need and age. Symptomatic breast engorgement will occur in non-breastfeeding women around day 3 to 6 and can be associated with a small elevation or even fever for several hours of duration. Here we see again a diagram of the breast and their ducts, the sort of folding or basket-like musculature you can see in sort of the upper right. And when this contracts around a duct, demonstrated with the 2 open ducts below and the lacteals, you can see that again milk is squeezed through the green ducts and out towards the nipple. And you can see that there is both arterial and venous vasculature that surrounds these various lobules. There are a lot of mood changes also that occur of importance in the postpartum period. Approximately 50% of women will experience postpartum blues, which is characterized by a sort of transient mild depressive symptoms which includes sadness, crying, anxiety, insomnia, decreased concentration, and mood lability. The risk of major depression further is 4 to 11 times greater compared to women without the disorder. So postpartum blues can sort of be a stepping off, in a sense, towards a more important or significant problem, which is a major depression. Overall, the prevalence of postpartum depression is about 9%, although in some studies it is as high as 20%. And this is a rate that is similar to that in non-postpartum women. The thyroid gland also undergoes some changes. It increases to about 35% in volume during pregnancy. By about 12 weeks postpartum, however, it does regress to normal size. Although T4 and T3 also increase during pregnancy, they also return to normal fairly rapidly in about 4 weeks. However, postpartum autoimmune thyroiditis will occur in between 2 and 17% of women. And these women can present with symptoms of either hyperthyroidism or hypothyroidism. In fact, it occurs even more frequently in women with type 1 diabetes. Maternal weight. There's about a 10 to 13 pound weight loss at delivery, which is attributed to the infant, the placenta, amniotic fluid, and bleeding. However, this initial weight loss may not be manifested until 1 to 2 weeks due to the fluid retention that we just discussed a little while ago. However, by 6 weeks, unfortunately, only 28% of women will return to pre-pregnancy weight. And unfortunately, if women gain more than 35 pounds during pregnancy, they are likely to end up with a net gain of about 11 pounds compared to their pre-pregnancy weight. So again, it's an issue that certainly many women sort of struggle with postpartum, and again can be solved again with a variety of challenges with both diet and exercise. There are urinary tract system changes. The renal collecting system dilates during pregnancy, right side greater than left, but returns to normal caliber by about 6 weeks postpartum. The GFR, creatinine clearance, and renal plasma flow, although they increase during pregnancy, they also return to pre-pregnancy levels by about 8 weeks postpartum. So this ends this part 1, which is just reviews some of the physiologic changes that occur in the postpartum period. The next video will talk about some of the complications and other issues that arise during this time period.